We're now going to hear from Professor Louise Newman. Safe Mothers, Safe Babies is the name of a project being undertaken by the Centre for Women's Mental Health, which is led by Professor Newman, and she'll tell us more about approaches to perinatal intervention for women experiencing and at risk of family violence. So please welcome Louise.
Thank you. Thank you very much. I'd like to acknowledge the traditional owners of the land and also ask you to spare a thought for the plight of asylum seekers on Nauru and Manus Island, many of whom are women and children who are experiencing daily violence and sexual assault. So I'm going to talk today about a project which we're beginning at the Women's Hospital, Safe Mothers, Safe Babies. And I should say it's proudly sponsored by Liptember and Chemist Warehouse, so thank you to them. So this is translational research into the family and interpersonal violence area, where we're seeing pregnancy and early parenting as key areas for intervention. And we take the approach that the issues are very much around women's health and well-being, women's mental health, but also about infant development. There are two victims here when we're speaking in this context about pregnant women and women in the perinatal period. Antenatal care, of course, is a major opportunity to better identify women who might be at risk or experiencing interpersonal violence. Many women might attend antenatal services when they might be reluctant to attend many other services. We sometimes, but not always, have opportunities to discuss risk issues with women in the absence of partners, though not always. We're interested in enhancing the capacity of antenatal care for risk identification, but also importantly for response, an integrated response that's obviously providing initial information and support, and there's been a lot of discussion recently about that, but also about providing mental health support and helping women deal with trauma-related mental health problems that many who are experiencing violence are going through. Many have histories in their own backgrounds of long-term risk factors for trauma and mental health problems. Many are currently depressed and certainly experiencing anxiety, and many have tremendous anxieties about the welfare of their developing baby and how they'll cope with parenting. So ideal opportunities which may move beyond the traditional approach of giving advice. So we're developing targeted mental health and psychosocial support approaches that are both accessible but deliverable in the multidisciplinary context of the Women's Hospital. And it should be said that this is quite an unusual program. There are currently very limited mental health programs available, despite the fact that we know a lot about the mental health problems of women who are in these sorts of situations. So the issue is that family violence increases in pregnancy for complex psychological reasons, sometimes to do with jealousy, envy, and partners may be feeling displaced by a woman's attention to her pregnancy and her own health. 20% of new cases of family violence begin during pregnancy, and that's first onset. We also know that stress and anxiety in pregnancy impacts mothers' mental health as well as infant development. Infants who are exposed to ongoing chronic stress in mothers are more likely to have developmental problems, they're more likely to be born early, they're more likely to have small head circumference and a range of physical problems as well as difficult deliveries. The rates of pregnancy complication are much higher in women who are assaulted during pregnancy. So this has led us to consider this response of using the antenatal clinic and certainly not wanting to maintain this approach only within hospitals. Ideally, this is a clinical approach that could be offered by anyone who has contact with pregnant women in whatever setting. But obviously we're starting to evaluate it in the hospital setting. There's obviously a need to support women in protecting their own mental health and well-being, but also the health and development of their baby. The Women's Hospital currently offers programs in both the antenatal and the postnatal setting for women experiencing a range of mental health problems, but particularly stress, anxiety, depression. And we also see women with substance abuse issues. Many, of course, are in situations of ongoing violence, exploitation and abuse. And we'll be using a similar approach for women that we identify in the antenatal period. The sorts of approaches that we're interested and are using currently in other work, and we'll use in this group, are what we might call interactional approaches. So it's helping women think about themselves as a parent, as an attachment figure, and thinking about the sorts of care and protection they would like to be able to offer their child, even in the face of the risk situation they find themselves in. So this is very much a window of opportunity to discuss these issues about parenting and child protection, as well as self-protection with women. Parenting with Feeling, PWF, is a postnatal mother-baby group program which we're running and evaluating at the moment for women with risk factors, and we'll be having a group program specifically for women in these higher risk situations. The NBO is the Newborn Behavioural Observation, which is a technique for helping mothers understand the social and interactional capacities of infants and help them establish a better relationship with their baby. And I think what we need to remember is that many of these women, regardless of the risk factors and difficulties they find themselves in, are highly motivated to parent effectively and safely. That becomes their first priority. It's both a barrier sometimes to help seeking because of concerns about a child removal, but it's also a great opportunity if we can engage in a more appropriate and non-judgmental way with women in a help-seeking way where we actually better engage them. And we'll be able to do some follow-up, which will be focused on infant-parent relationship and child development. So the components, as I've mentioned, are listed there. Initial screening and identification, and it should be said that having reviewed the available screening instruments used around the country and also internationally, many of them are untested. The psychometric, the data available is very limited. They also ask very direct questions in many occasions, and we know from discussing with women in these situations, they're unlikely to answer the questions. So I think there are big question marks over available screening instruments. We're developing our own very brief approach to asking around the issues of safety. So as opposed to asking, are you being hurt, physically beaten, assaulted at home, which some of these questions ask, which in my experience, women on a first meeting with an unknown clinician are not going to answer. In the majority of cases, issues of safety, concerns that they might have about their pregnancy and their capacity to parent are much more likely, in our view, to lead to that conversation where we can actually maybe identify greater risk factors. So that's the approach that we're taking. We will then obviously refer those women to appropriate supports, resources and information as the hospitals are working towards, but we are adding a mental health assessment for those who are wanting that to look at trauma-related difficulties, issues to do with self-esteem, capacity for self-protection, the need for treatment of depression, and we'll be following women through the antenatal group program, which is called Mind, Baby, Body, which is about dealing with stress and anxiety and transition to parenthood, and then through the postnatal group. This is very much seen as a prevention strategy in these high-risk dyads. Our intervention approaches focus on improving parenting, emotional attunement, and women's capacity to think about themselves as a safe parent. And this is transformational for many women who, in many cases, as you're aware, have major risk factors in terms of difficulties in relationships, low self-esteem, histories of abuse and trauma. Parenting and getting it right is of fundamental importance to these women. I think it's important that we actually respect that by using the language of attachment and the sorts of interventions that they're much more likely to engage in. Thank you. I'll stop at that point. I'm running out.